episode of webinars that have been enabled by GCCMC. GCCMC, as you know, is a global coalition for medical care in the COVID times. It's enabled by Wipro. The vision of this whole series is not just a webinar, but there are e-learning modules that we have created. There are resources that we have created. There are podcasts that have been created. More importantly, a e-learning platform that has been created, all for the medical fraternity to use without any strings attached. And the reason was we felt there was a need to make sure that there are some right tools available for the medical and healthcare fraternity during the COVID time. In fact, we've done some very interesting webinars in the past, whether it is looking at ECMO, but even an interesting webinar where we said let's look at how doctors are doing financially during the COVID times, and how to actually not waste your money on real estate. No, but the important thing was financial planning was a webinar that we did. We did one on how nursing homes can pick up their pieces and start working. So we've been looking at this has been looking at trying to support the healthcare community. To cap it all today, I have a very dear friend, Dr. Mangesh Tivaskar, who the country needs no introduction. And I've been waiting to ask Mangesh that put together a program for us that looks at the post-COVID scenario. While Maharashtra is defying all the trends of moving into a post-COVID scenario, Mangesh himself is one of the experts in the country in internal medicine. He is soon to become the editor-in-chief of JAPI. More importantly, he's a wonderful human being. And Mangesh together has put together a wonderful team of legends in this field, including chest physicians and psychiatrists, who will all talk to you about the post-COVID syndromes that are coming into our clinics, and somehow we are missing them. Mangesh, with this, please take over.
Thank you, Krishna. Thank you for those kind words, and it's been always pleasure and a privilege to be associated with you. In fact, I was looking for an opportunity to somehow or the other, have a kickoff program with you. To be very honest and to confess that you have been always my role model as far as the perfection, the work ethics, the quest not only the quest, but the perseverance that you have for an accuracy and for the brilliance and the genuinity of the data. It's worth saluting and worth mentioning. I'm truly thrilled to be there with you all, guys. And thank you all, and good evening, everybody. I am Mangesh Tivaskar, Secretary, Association of Physicians of India National, along with my entire team, my guru, my everything in the field of medicine. Apart from field of medicine, I would say that being a human, who better person than Dr. Manoj Bhatodekar sir, the leading psychiatrist of the not only city of Mumbai, but country, a key opinion leader in many aspects. And I'll introduce him when I formally introduce him, along with my very, very, very close friend, my pal, my soulmate, Dr. Agam Vora, who is going to be a future API General Secretary after I take off my shoes. Along with him, I have none other than the best of the best in the physician world community. Nobody knows, nobody needs any, I would say, formal introduction of this guy, Professor Dr. Ketan Mehta, currently working as the Vice President, IMA Mumbai West, physician par excellence, son of a physician par excellence. So medicine runs in generation of Ketan, and that runs in his blood. Thank you, Ketan. Thank you, Agam, for being there. And of course, I love to see the team Wipro. Thank you very much. And to set a context, talking about a COVID, a virus which has changed our lives. We have learned a lot. Since last 1.5 years, I would say that the things have changed. Not 1.5 years, but definitely last 1 year, I can say 1 year, 3 months. Since the time the COVID was invented in the city of Wuhan, China, our smallest possible virus, which has changed everybody's life. We have started living differently. We have started working differently. We have started understanding differently. We have started analyzing differently. And not only that, We have started being together differently. COVID has brought us close and very close, not only to the globe, but to the communities which are not reachable so easily in whatever the ways of communication. And here we are to have a program on the post-COVID phase. But are we really in a post-COVID phase? Partially, yes, because now it's almost a year-old disease. So a lot of patients, those who are recovered from COVID, they are into this post-COVID phase. Even though the earliest patients, those we have seen, they still are persistently in this post-COVID phase. And initially we thought that post-COVID syndromes or post-COVID sequelae may be possibly a pulmonary sequelae. But then as the time advanced, as the science advanced, as the information advanced, we started coming to know that no, there is a psychiatry angle to it, there is a cardiology aspect to it, there is a general medicine angle to it, there is an endocrinology angle to it, there is a diabetes angle to it, and there are every possible angle to it. So COVID has changed our perspective of clinical practice. So let's kick off today's post-COVID session with one of my closest, my dearest, my soulmates. Not a day has passed in last 25 years. I remember that I am not spoken to him at least once or twice in a day. Initial days we used to have our coffee together early morning. Agam Vora, chest physician par excellence. India doesn't need any introduction about Agam. Agam is currently a chest physician and pulmonologist practicing in Mumbai at Vora Clinic. He has his own setup in the name of Advanced Medical Hospital. He is an ex-professor of pulmonology in R.M. Cooper Hospital and KG Somaiya Hospital. Currently, Agam is on the governing body of Association of Physicians of India and is a member of the IMA Mumbai West branch. But apart from that, Agam is a wonderful human. I will keep on talking of Agam, giving me a chance. This is Agam for you. Agam, over to you. And Agam would be speaking to us on post-COVID lung fibrosis, one of the dreaded complications we all feared about. Dr.
Good evening, everybody. And thank you, Dr. Mangesh Tivaskar, for those nice words of introduction. Indeed, today's program is really special to me. There cannot be, anybody better than your close friend introducing you. It's very unusual to hear nice things from your friends. I always thought friends are for having coffee together, friends for having fun together, friends are for sharing jokes together. And I really used to wonder when I used to read about a friend, philosopher, and guide. I never believed a friend could be a philosopher and could be a guide too, till I met Mangesh. And my journey with Mangesh for almost 2 decades, as he rightly said, not a single day without meeting, not a single day without talking. And that makes it very special today. Today's day is also very special as I'm talking on GCCMC platform. I've been hearing about this platform for almost a year, and I believe they've done wonderful programs. In fact, when I interacted with Dr. Seshadri and when Mangesh spoke to me about it, I realized they've done fantastic programs, not only on COVID, on financial aspects, doctors' health, doctors' psychological issues. They've done on vaccination, etc. And I was waiting to probably have join hands with them to do some program. And today my dream has come true. So I express my sincere thanks to my teacher, Professor Director Dr. K.C. Mohanty. Of course, this GCCMC platform, which is a Wipro platform that is designed to bring together a medical professional to share knowledge and best practices during these unprecedented times. I've been interacting with Mr. Pratyush Gupta and of course Dr. Sheshadri and the entire team. I must also take a minute and thank the Academy of Advanced Medical Education, where Dr. Ketan Mehta, Dr. Mangesh Tivaskar, Dr. Arvind Gongane have worked together. And in the last 1 year, we have also done more than about 110 web CME programs and probably have published 4 different papers. And we'll be talking about it in some time. Of course, my co-speakers and all delegates who chose to be here because your presence encourages us. It is only because of your presence we are thrilled to do this kind of programs. Let's take a few seconds silence for those 119 million cases globally, 2.64 million deaths across the globe, 11.3 million cases in our country, with almost 160,000 deaths. My Maharashtra is probably topping the list with 2.28 million cases with almost 50,000 deaths. Something unprecedented happened. As Dr. Tivaskar said, 2019, last week, a small city, China, Wuhan, had a small virus, a 100 nanomicron virus. And this virus challenged the most evolved species on Earth, that is we human beings, and our whole existence was challenged. It affected us on various fronts. It affected us socially, psychologically, it affected us financially, it affected us, we realized the lacunae we had in our administrative powers, we had lacunae in our healthcare system. We went through, it was a new disease, we did not know much about it. We went through different treatment protocols. We started with multivitamins, anti-Helminth drugs, we started with minerals, we started with immunomodulators, we started with all herb or mineral preparations, we started with steroid, we started with doxycycline, we started with ivermectins, we started with old antivirals, then we were given new 2 antivirals, and then so on and so on. We used even biologics. And after about 5 and 6 months of brainstorming and different experiences and different studies, and we could now probably are in a little better position to understand this disease. We've realized it as a early viremic phase and a little late cytokine phase. This patient may have different kind of presentations. And now what we are seeing is post-COVID syndromes. Post-COVID, and that is what is going to be the gist of my presentation today. We are seeing variety of complications. I'm seeing, though as Dr. Tivaskar said, COVID is not over. But all those patients who have had COVID, who had a bad COVID, who had extensive involvement are presenting now with post-COVID complications. And these are the list of complications that I see in my practice. Type 1 respiratory failure, organizing pneumonia, progressive fibrosis. I'm talking about that small subset of patients who will have progressive fibrosis. We are not talking about the reparative fibrosis. We are not talking about the scars that patients has after the consolidation. We are talking about progressive, the more fibrosis that happens. Pulmonary hypertension. We have used steroids, we have used biologics, all that would lead to secondary infections. I'm seeing reactivation coughs, I'm seeing fungal infections. We are seeing pleural complications. I'm seeing pneumothorax, I'm seeing pneumomediastinum, I'm seeing pleural effusions. We are seeing thromboembolic disease, lung infarcts. We are seeing variety of other systems, cardiac, neuromuscular, cerebrovascular. I'm seeing depression, anxiety. There's going to be a special talk there. Restricting my talk to pulmonary fibrosis, it is the pathological consequences of acute and chronic interstitial lung disease. It is characterized by unsuccessful reconstructions of damaged alveolar epithelium, persistence of fibroblasts, and excessive deposition of collagen and other ECM material, as well as destruction of normal lung architecture. Emerging data say that up to 17% of these patients can develop fibrosis. That means whatever scar, whatever involvement you see radiologically, be it mild, be it moderate, be it severe, significant proportion of patients may have complete recovery, but as high as 17% may have a scar which remains, fibrosis which remains or develops. It could be viewed because of this disordered wound healing process and may be directly related to severity of event. Various mechanisms are described, both viral and immune-mediated mechanisms can do it. The early virus phase could do it, and then comes the hyperimmune phase or the cytokine phase, which can also lead to damage and a progressive fibrosis. Additional factors could be responsible, which predisposes an individual to this fibrosis. Result of severe inflammatory response to COVID-19, including the cytokine storm, the regulatory pathways are activated to counteract and heal the damaged tissue. If this balance is disturbed or it is prolonged, it may result in fibrotic response, which is manifested in different forms on CT. Like you may have interstitial thickening, you may have ground glassing, you have irregular interface, you may have cause reticulation and the parenchymal band. Various studies which talks about this study came up a little early, which talks about as high as 83% of these patients developing fibrosis. These patients were all hospitalized patients. So all those patients who have severe disease, who have extensive disease, will definitely lead to fibrosis, and this fibrosis could be seen in significant proportion of patients. But the relief is significant fibrosis resolves in most of the situation. So you look at 4 months or 6 months time, and all this fibrosis reverses completely, and your parenchyma becomes almost normal. In small proportion of patients, there is static. In the sense, the fibrosis persists. Whatever areas are damaged, there could be fibrosis, and this fibrosis does not go. It leads to that kind of parenchymal damage. And in small proportion of patients, even smaller, there is progressive. In the sense, the fibrosis increases. There is disproportionate fibrosis, and this probably is the group where there could be a role of therapy with anti-fibrotics. What are the mechanisms? COVID virus gives to TGF beta level elevation, angiotensin 2 level, reduce S2 receptors, leads to myofibroblastic activation and ECM accumulation. Both together leads to lung fibrosis. And to add to that, there could be ventilator-associated lung injury, and there could be hypoxia, which adds to this lung fibrosis. We've had this earlier. We've had this in SARS, we've had this in MERS, and this recent data suggests that this viral infection could be associated with increased risk of IPF. That means they behave like idiopathic pulmonary fibrosis. So we call it idiopathic since we do not know the etiology, but they now believe that certain viruses may have a potential to trigger this IPF process. So how does it happen? Following viral entry, the innate immune system recognizes virus using pathogen-associated molecules which interact with antigen-presenting cell. Toll-like receptor 7 on macrophage is capable of recognizing this single-stranded RNA, and it leads to intracellular signaling, activation of nuclear factor KB, which induces expression of pro-inflammatory factors and interferon regulatory factors. Combined effect of this virus-induced cell injury and the inflammatory mediators is responsible for lung damage, which happens in COVID. It can have completely asymptomatic or mildly symptomatic cause, as we all know. This patient may have completely mild cause, but in some patients, there may be no viremic phase. Patient may be asymptomatic and begins only with cytokine phase. I have, in fact, 3 patients who are admitted, had very mild phase to begin with. They had hardly fever for a day or two. And on 6th or 7th day, their cough increased and they probably went into the hyperimmune phase, had cytokine storm kind of presentations and probably lung damage that time. The similar cytokine profiles in IPF and COVID-19 suggest there could be analogous pathomechanisms of pulmonary fibrosis in those diseases. Therefore, drugs useful in treatment of IPF could also be beneficial in COVID-19. Various risk factors, needless to say, age, probably you would see in elderly patients, there may have problems in reparative process. Older people are more likely to develop fibrosis even following MERS. An exact reason is though unknown, but I believe it's a failing and waning immunity which is responsible for this damage. Illness severity, of course, more severe disease, more chances for them into developing into fibrosis. Prolonged stay, of course, if patient has more severe disease, has got more cytokine phase, has got more comorbidities, he would need prolonged stay, and people who have long stay had higher chances of having persistent fibrosis. Of course, patients who went on ventilator, we've lost significant number of patients who went on ventilator, but patients who were survived, who revived out of this ventilator, had fibrosis and which persisted for a long time. The abnormalities in pressure and volume settings on this ventilator could also be factor responsible for this. Smoking, yes, smoking also is associated. People who are smokers and who developed this had more chances of pulmonary fibrosis. True with alcoholism as well. It is speculated that interstitial thickening, irregular interface, pause reticular pattern, and parenchymal bends, which you see on CT, probably this features could predict pulmonary fibrosis. So if you have only ground glassing, or if you have only consolidation, you have only crazy paving patterns, this pattern could reverse completely without leaving any scars in time to come. The pulmonary fibrosis is associated with significant reduction in quality of life. There are various anti-fibrotic drugs available which have shown some promise in clinical trials. There are doctors who have started upfront anti-fibrotics. There are a few trials which are undertaken where anti-fibrotics are used on day 1 of the presentation. And there are some who, like me, believe that they should be used only if fibrosis is progressive. Because to my mind, the fibrosis which happens in organizing pneumonia is a reparative fibrosis. There's a repair process going on. And there you don't require anti-fibrotic drugs. But probably trials would tell us more. And there are various other factors where we need to put our focus to modify the outcome, which is probably ventilatory strategies, smoking cessation, alcohol, probably usage that needs to be reduced. And in hospital, probably various other ways of improving oxygenation, like prone ventilations and breathing exercises, etc. Anti-fibrotic drugs, I said, it would be effective maybe in some cohort of patients, but we need to do more studies to understand its actual role and identify the right cohort of patients who would benefit. Potential benefits, probably acute lung injury, it is difficult to study. Putative treatment benefits with antifibrotics and reducing prevalence of acute exacerbation were observed in patients already established on antifibrotic therapy. In antifibrotic therapy, in IPF group, yes, there is a documented advantage of using antifibrotic therapy, and probably taking clue from those trials, we may extend the use of antifibrotics in few needy patients. Pirfenidone and nintedanib are two approved antifibrotic drugs. Both have different modes of action, but both are effective in attenuating rate of reducing lung functions and rate of exacerbations in idiopathic pulmonary fibrosis. So it is not that you will use only antifibrotics. You must use potent antivirals. You may have to use other drugs, like probably Ketan is going to talk about anticoagulation. We may have to use about various antibiotics if required. We may have to use anti-inflammatory drugs. We may have to use biologics if required. And then probably in small subset of patients, we may even think of using pirfenidone, which is anti-fibrotic, antioxidative, and anti-inflammatory, and nintedanib, which is tyrosine kinase inhibitor, having again activity against growth factor receptors. And these are various things which are in pipeline. Maybe in time to come, we would understand more about drugs which would help in reducing fibrosis or could be anti-fibrotic. Currently, first two are available. The rest all are currently in research. So you have nintedanib and pirfenidone, and they have inhibitory effects on interleukin-6. They have inhibitory effects on interleukin-1 as well. And the experimental lung injuries are definitely reduced when antifibrotics are used. So currently, doubtful role in small subset. Yes, steroids have a significant role. In the organizing pneumonia phase, yes, steroid is the mainstay of treatment. Literature mentions about its use for 7 to 10 days, but in practice, most of us use it for about 3 to 4 weeks, depending on the extent and associated comorbidities. Novel agents, yes, time to come. Ripamycin would be another drug. There are various drugs which are repurposed during this unprecedented times. Oxygen support, pulmonary rehabilitation forms the mainstay, and the small subset of patients who continue to have irreversible or refractory respiratory failure, who are confirmed COVID negative, and who do not have any other comorbidity or any other organ dysfunction which cannot be managed, can be considered for lung transplant. We have initial experience. We have got a couple of patients who are subjected to lung transplant and are doing well. So initial experience is, of course, encouraging. It can be performed in end-stage patients with respiratory failure due to COVID-19 related lung injury. I would summarize my talk by saying that COVID-19 pandemic will have huge economic, social, and healthcare impact. Post-COVID-19 fibrosis is one of the most important complications, and I'm sure, irrespective of your practice, we are going to see this kind of complication. We are going to see this kind of patients in our OPDs. Current and emerging novel therapies may have therapeutic potential for this COVID-19 fibrosis. Allow me to share one case. This is the patient where you can see that there are 3 CT scans. Horizontal line shows CT scan. And you could see that there is first CT scan, second one is taken 2 weeks later, and third one is taken 7 weeks later. Between first and second CT scan, you can see that there is increase in the lesion. You can see the ground glassing has increased. You can see that there's a lot of air trapping as well. There is a centilobular emphysema. So this patient was a case of combined pulmonary fibrosis with emphysema. It behaved like something called as combined pulmonary fibrosis and emphysema. We call it a CPFE. And this patient was treated with appropriate treatment. And you can see that in the last scan, there is significant improvement, but still there is a lot of fibrosis. There is a lot of ground glassing improvement. It is replaced by fibrosis and traction bronchiectasis. So these are the patients who developed significant pulmonary fibrosis at the end of 7 weeks, and this would be the patient. This kind of patient would be the ideal patient where one could think of using antifibrotics. I would end my presentation with this personal experience. Me and Mangesh together have had the opportunity to treat almost 1,500 patients, which includes both home treated patients and the indoor patients, of which 216 required ICU, 48 required ventilator. I'm very sorry to say that I lost almost 46 patients. Only 2 patients were, came out of ventilator, and then we changed our strategies. I have almost stopped putting our patients on ventilator, and we manage this hypoxia till end, in the sense we try all possible things to manage hypoxia, and we accept hypoxia levels that I would have not accepted otherwise. In pneumonia, I would have not accepted. In COPD, I would have not accepted. But here in COVID, I'm accepting very high drop in oxygen levels and managing them conservatively till they go into respiratory failure, until they go into probably the respiratory muscle get exhausted, and I have no option but to put them on ventilator. 216 had organizing pneumonia, and this is all patients with organizing pneumonia required ICU. 16 recovered in 45 days. Almost 200 patients required oxygen therapy beyond 45 days. 137 out of that had complete radiological resolution. I'm very happy to say that you wait for 3 months and 4 months, and most of this patient completely resolved. 63 had residual lung damage and persistent hypoxia. 27 had progressive damage, worsening of fibrosis. That means out of 1,500, only 27 patients had progressive fibrosis, and I've used these patients on anti-fibrotic drugs. And I have 7 patients on both. Currently, there is no rationale of using both drugs, but in situations where I could not use full dose of each anti-fibrotic, you know that pirfenidone is available as 801 milligram tablet, and the ideal dose would be 1800 to 2400 milligrams a day. Nintedanib is available as 150 milligram, 100 and 150. We are supposed to use 150 milligrams twice daily. Nintedanib is associated with loose motions, and pirfenidone is associated with gastritis. So I have a situation where I could not use full dose of both drugs, where I've used half dose of both drugs. I've used nintedanib 100 milligram twice daily, and pirfenidone probably, somewhere around 900 to 1200 to 1600, with whatever maximum I could use, and have combined this 2 drugs. Though I don't recommend it, but there are newer studies available, they're ongoing, which may talk about the combination therapy in time to come. Thank you very much for your patient hearing, and we would take up questions if done at the end. Thank you. Over to you, Mangesh.
Thank you, Agam. As usual, there was a rocking talk actually. And friends, to share with you that this was in last month's data. There are a couple of more 100 patients that must have added over the last 1 month's time because of the spike that we are all experiencing. And me, Agam, Dr. Ketan, Arvind, we are all team working on all these features of COVID. We'll be coming out with all these updated knowledge for all of you, whenever I get a chance. There are a few announcements that I want to make, that please, if at all there are any questions, please do type in your questions in the chat box or the question and answer section. I would definitely take those questions from all of you. We all have experts which have been, champions in these fields. We'll make them to answer your questions. I too myself have a lot of questions for these experts. So I'll surely do that. It's a pleasure to see you, Dr. Arvind. Welcome. And now we have, who else better I can say? Whenever I try to talk about him, I really realize that how words have their own limitations. When you want to use correct expressions for somebody of ability of my teacher, my guru, Professor Dr. Manoj Bhatodekar, leading psychiatrist not only in the country, but I can tell you that he is an example himself, a living legend in the field of psychiatry. KOL to many fields, runs so many beautiful projects. So he's been responsible for conducting those wonderful programs for Juvenile Diabetes Foundation. So he's a prime worker in the field of schizophrenia and also the mental upgradation and psychological health in multiple schools in Mumbai. Sir is a spiritual advisor as well, along with being a legend psychiatrist. Sir has got a beautiful spiritual angle and a belief which is added to a psychiatry, which has added a different dimension to his expertise. And here we have Dr. Manoj Bhatodekar, sir, guiding us on what are those challenges, those psychological challenges that we all of us never thought that they will come ever in our life. But I'll tell you that this has become even more difficult challenge than any other structural challenge that we have post-COVID phase, are the psychological impact, psychological challenges PTSDs, like post-traumatic shocks, and depressive behavior, suicidal tendencies, financial challenges, which puts the patients on a social disconnect. Coro anxiety is one such kind of a problem that we all face. Fear, which has come up. So as my friend Dr. Shashank Joshi says, that we were in what we call it as an AC era, that is the BC era, that is before Corona era. Now we are into called as a DC era, that is a during Corona era. We hope to see AC era very soon, but we have changed as being human beings. Over to you, Bhatodekar sir, to guide us on the post-COVID psychiatric challenges. Welcome.
Thank you, Mangesh, for your kind words. I hope I'm audible, Mangesh. Am I audible? Yeah. Okay, thank you. At the outset, allow me to thank the organizers for having included a psychiatrist in this panel, because we psychiatrists do a lot of work silently, and we are under the impression that nobody notices it. But I'm sure it's not so. And today I'm here among all of you to share some evidence, some experience about post-COVID mental health challenges. Just allow me to share my screen. Is it visible?
Not yet, sir.
Just a moment.
Yeah, it has come up.
Okay. Okay.
So your slides have come, sir.
Yeah, just a moment.
Yeah.
Yeah. So in today's presentation, what am I going to talk about? I'm going to talk about the neuropsychiatric psychological impact of the COVID crisis on human life, and difficulties faced by mental health professionals because of this crisis. And finally, is there a hope, is what we are going to look at. So it's a pandemic with an unknown end, and there have been lots of studies which have kind of predicted a projection into the future about various psychiatric issues associated with the pandemic based on earlier pandemics. And so some of them are retrospective studies and some of them are prospective studies. And now recently again, there is a flurry of retrospective studies which has come up. So there is definitely a change in the mental health scenario. Let me tell you one thing, that in March, once the lockdown began, March 2020, till April, maybe first week, I was taking it easy, just calling up patients and looking after their well-being. And then I started, in the first week of April, I started doing teleconsultations. And looking at your patient with a two-dimensional view, whereas psychiatry really requires 4 dimensions, not just 3, right? So there's something behind and above and beyond the third dimension in a patient that we need to see. But we had to start doing telepsychiatry. The whole presentation of the pandemic was uncertainty, sense of danger, and loss of control. Then we also saw a rise in certain clinical conditions, clinical psychiatric conditions, and we also saw the need for newer forms of treatment. I still remember my first encounter with a patient who was an old patient of mine who flared up, he had schizophrenia, and I still remember his call in April. He calls up saying that, "Doctor, I have a knife in my hand and I have locked up my father in the room. And if you allow me, I'll kill him." First of all, I said, "Thank you very much for calling me." And I thank God that he called me in the first place. Okay. Then I had a 40-minute session with him over WhatsApp video where I just pacified him, talked to him, allowed him to speak, and gave him a patient listening. At the end of 40 minutes, he was willing to keep the knife away and then open the door and let his father out of the room. And then he allowed me to speak with his mother as well. And then he accepted medication, and today he's fine. The point is, these kinds of scenarios have been a hallmark of this lockdown period. You know, different kinds of scenarios I can go on narrating, but we have a limited time. So let me restrict myself to the points that I have enlisted. And then, so as I said, there is need for newer forms of treatment, and there is increased need for training of non-psychiatric clinicians in treating common mental disorders like anxiety and depression. So this is very important. So here is a case of a 12-year-old boy who lost both his grandparents to COVID. And he presented with extreme irritability, washing hands every 30 minutes and making his parents also wash their hands, refusing to attend online school, having nightmares, and wanting to break the rules of quarantine and get out of the house. So his diagnosis was OCD with severe anxiety, and it was obviously there is an element of trauma which triggered the whole thing. The second case is that of a 62-year-old woman who was hospitalized for COVID, and following hospitalization, she presented with vivid flashbacks of memories from the hospital. She was in the ICU, so she would wake up with nightmares, and even while she was awake, she would get vivid flashbacks of memories like people are poking her, and then she's put on a ventilator, and then she's not able to breathe, and that she's smothered and all kinds of stuff. She lost her sleep. She had severe fatigue. She used to cry continuously. She said, I've become foggy. I cannot remember things. I've become forgetful. And there was a persistent feeling of loneliness even after being with the family for a month after discharge. Yeah. The third case is that of a 40-year-old man who was discharged from COVID ward, who started worrying excessively, also because there was a probability of his losing the job. This is another major fallout of COVID crisis. He lost his sleep, complained of severe breathlessness in spite of his SpO2 being normal, complained of palpitations, nausea and gases. He was put on pantoprazole and antacids and whatnot, but still his nausea persisted. He lost his appetite. His diagnosis was obviously anxiety disorder. And this woman, the 62-year-old woman that we saw, was post-traumatic stress disorder. Yeah. Now, there are several studies which have shown that there are mental health impacts of quarantine and social distancing itself. Forget the COVID infection. After quarantine, people have complained of insomnia, irritability, symptoms of post-traumatic stress disorder, considerable long-term impact for months to years. This is what needs to be remembered. Social distancing can cause loneliness, anxiety, depression, domestic violence, child abuse, and substance abuse. Then there is a syndrome called Hikikomori, which is a social withdrawal phenomenon aggravated by economic and social crisis. Yeah, it's a Japanese word. Then there are studies about patients who have been diagnosed and treated for COVID. So in the acute stage, delirium is very common. So I'm sure those of the physicians who have been working in the ICU have seen these kinds of delirium. Then there is neurocognitive impairment in terms of impaired attention, memory. Many patients I have seen after coming out from COVID ward, for several months, they say that they not only have physical fatigue, but they also have a lot of mental fogginess, mental fatigue. People say that I'm not able to process information with the speed I used to earlier. I'm experiencing as if I'm developing a memory impairment. And so overall mental processing, the speed of mental processing is reduced considerably. Then there is reduction in quality of life of patients who are on prolonged mechanical ventilation. So these are the findings from studies. Another thing is, I have had the opportunity to interact with so many healthcare professionals during the COVID crisis. I've had group sessions with them, individual sessions with them, and findings corroborate that many of them have anxiety, depression, insomnia. I mean, I've had examples where doctors have told me, the moment I think of the PP, I start getting palpitations. I don't want to wear a PP. I don't want to wear even a mask. It's that scary. And highest risk of adverse psychological reactions in healthcare workers has been found. Also, there has been a lot of stigma which is associated with working in a COVID ward. I mean, I have had colleagues who have come and told me that people have kind of started looking at me as an outcast. No, you've come from a COVID ward. I don't want to be with you. I don't want to be in your company, that kind of thing. This is very interesting. There is a bi-directional association between COVID-19 and psychiatric illnesses. It's a study from Lancet, recent study. And it is found that the rate of all the diagnoses of psychiatric disorders, including relapses, was higher after COVID-19 diagnosis than after control health events. So they compared this with other health events, and it was definitely found that psychiatric disorders were high. And also, on the contrary, having a psychiatric disorder in the year before the outbreak of COVID-19 was associated with a 65% of risk of COVID-19 with a cohort matched for physical risk factors. So just imagine the importance of having a good mental status. And very few people talk about this. Very few people talk about the role of mental health in having a good immunity. I'll come to that a little later. And this is another study where as you can see from the chart, that there is a significantly increased mortality rate for patients with a psychiatric diagnosis. So 2 weeks, 3 weeks, 4 weeks, you compare the figure psychiatric versus non-psychiatric, there is a significant difference in mortality rate. So people with high psychiatric predisposition have high mortality rate when it comes to COVID. This was a prediction made by Megan Brooks in April 2020. Is this the next inevitable pandemic? And then there were steps which were suggested, like, to plan for the inevitability of loneliness and its sequelae, and some steps to intervene using digital technologies to mitigate the impact of social distancing. Then they also talked about using places of worship, gym and yoga and other places which people normally gather to offer regularly scheduled online activities. Also using virtual technologies by educational institutes and employers. And this was immediately implemented, right, all over. Now, what happened as a result? Have these 3 steps worked? What is our experience? they have worked, and they have not worked. The commonest finding experientially, I would say, as a clinician treating psychiatric patients, was that people allowed their lifestyles to be disturbed grossly during the lockdown. Sleep, mealtime, exercise, relaxation, work. People who worked from home, normally that a person who would leave home at 8 o'clock for work, commute for an hour, reach his office at 9 o'clock, started saying, oh, I have to work from home. Where's the hurry? So let me start my work at 10:30 a.m. It's okay, it's allowed. And then go on till 11, 11:30, 12 at night, which otherwise would have been different. He would be back home by 8 o'clock. So people's lifestyles got disturbed. And people with, we're talking about comorbidities like diabetes, hypertension, heart disease. These are essentially disorders of lifestyle. And I have seen many people whose basic physiological parameters, metabolism, they have got decompensated as a result of disturbed lifestyles. There's too much of being together at home, which people are not used to. So for some, it was a blessing. I mean, I have had people who have told me that, look, now I get to spend time with my family. So it's a blessing. For some, it was, oh my God, I have to stay with my family. I don't get along with someone and I need to be with that person all day long. It's miserable. So as a result, child abuse increased, domestic violence is increased, substance abuse has increased, alcohol abuse has increased. I have seen several female alcoholic patients during the lockdown period whose drinking was surreptitious before the lockdown, and it suddenly come to surface. Yeah. Which disorders have increased? This is my experience: anxiety, depression, post-traumatic stress disorder, sleep disorder, OCD, obsessive compulsive disorder, alcohol and substance use disorders. So finally, is there a hope? We are looking only at a tunnel which is very long and dark. But we never give up hope. And hope is the only thing on which we humans survive, right? So I have always looked at this entire pandemic experience as I am reminded of the story of an elephant who was examined by 7 blind people. And each of them touched one part of the elephant and described the elephant according to their own perception of the part that they looked at. However, the holistic perspective somehow has been missing. And I think that perspective is provided by the psychoneuroendocrine immune axis. We are all familiar with this diagram. So some studies, very interesting studies I have found, which are all evidence-based studies. There is a journal called Journal of Aging, research on aging. So this is where I found that these things, slow breathing, contra-resistance respiratory training, that is against resistance, meditation, prayer, autogenic training, which is hypnosis, vagus nerve stimulation. So certain techniques in yoga which stimulate the vagus nerve and thereby parasympathetic stimulation, nutritional supplementation like omega-3 and polyphenols, and melatonin supplementation. All of these have been proved useful in maintaining the PNEI axis. And the basic function of the PNEI axis, the way I look at this entire PNEI axis, is like an orchestra of different instruments playing together in symphony. And if one of the instruments goes out of tone, out of note, out of tune, the whole orchestra is distorted. And the very function of the PNEI axis is to restore homeostasis. We are talking about immune system. We are talking about an infection which is so dangerous, which is so morbid and potentially fatal in some cases. So are we able to target the immune system using some things which are very simple to practice, simple to follow? I'm telling you from my own experience, I have been myself into the practice of meditation very regularly for the past 20 years. In fact, that's a long story. Mangesh knows about it. Uh, in one sentence, I will just tell you, which is difficult to believe. If somebody had told me this story, I would have said you're telling me a lie, but I'm not telling a lie. Please trust me. And Mangesh is a witness to the whole thing. I suffered from severe rheumatoid arthritis in 1995. And today, with meditation, for the past 20 years, I'm in complete remission and off all medication. So please trust me. So I have experienced this. I have used this for several patients. And this is an evidence on functional MRI. Gratitude as a positive emotion has been studied a lot. And these are functional MRI studies of gratitude, which, gratitude versus resentment. And just focus on the left upper corner of the brain, which shows gratitude, and look at the areas which are marked. Look at the areas which light up on the functional MRI, and the same areas light up when a person is happy. So, what does it mean? If you want to be happy, all you need to do is to be grateful. So feel great gratitude, express gratitude, practice gratitude. And if we practice gratitude, we become happy. The serotonergic pathways, all the entire limbic system, the entire CNS that goes into our happiness is triggered by gratitude. So gratitude is a key, it's a door to happiness. And I have given this message in so many of my talks during the lockdown, and which has worked wonders with people. I have seen this happening. And so what is spirituality in its true sense? The word spiritual has nothing to do with a ritual. Even if there is a ritual in that word spiritual has nothing to do with a ritual. Spirituality, true spirituality is, it is science, number one. The only thing is, it is science looked from inside, subjectively. When you look at some things objectively, we call it science. When we look at it subjectively, it becomes spirituality. So true spirituality is all about being aware, being relaxed, receiving universal energy, being altruistic towards humankind, and being grateful. And so being grateful towards life as the innermost attitude. So people who follow these things have a strong immune system. They do not fall sick very often, and even if they do, they recover fast. And this is scientific. Before I thank everybody, I want to show this picture of a 90-year-old man who's currently admitted at Seven Hills Hospital with COVID. And in the right upper corner of the picture, you will find me chatting with him. And he is 90, no comorbidities, has been a very spiritually oriented person, has stayed in the ICU for 17 days and just come out of the ICU. And just recently, I mean, just yesterday, he's off oxygen. And he tells me that I am doing great. And for your kind information, he happens to be my uncle, who's next to my father. And I'm very proud of him. And I've been loved by him so much. And he's a source of inspiration. So on the other hand, I mean, on one hand, we are talking about morbidity and mortality of COVID. On the other hand, there are such examples, and I think they need to be highlighted. Thank you so much.
Wow, 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 wow. Thank you so much. It was truly inspiring, mind-boggling. Friends, here is Professor Dr. Manoj Bhatodekar. Apart from the psychiatry, far beyond excellence, is a trustee juvenile foundation. He is a writer. He published 3 books. Poets, superb poet. I have the collection of his poetry. And what I love about him is all his 4-liners. What we call it as Marathi, in Marathi, charolya, or in Hindi, you say char lina. But the way he writes is truly directly from his heart to your heart. a composer. He's a phenomenal musician. He's a singer. I'll tell you that he is a student of one of the legendary film music director and writer and composer, Yashwant Dev sir. He's a singer, not only a singer, he's now a facilitator in the medication and the meditation sciences. Thank you very much, sir, for guiding us on all. And we are going to come to you because I have a huge list of questions for you. Now, friends, who better than Dr. Ketan Mehta? I can clearly boast upon. To talk to us about one more aspect of post-COVID situation. We never thought that this would be an aspect or this could be an angle to a post-COVID scenario or as a part of the COVID. Initial months after our experience with the lung injury, we started realizing that these patients, they suddenly have started developing excessive pulmonary embolisms. There were thromboembolism phenomena. Not only that, there were a lot of DVTs reported in the post-COVID, especially in the ICU stays. And then we realized that that the COVID is not just the disease of pulmonary or the respiratory system, but also has got one additional angle to it, and that is probably the coagulation challenge that we have. So we in academia, along with me, Dr. Agam and Ketan being the prime investigator of the study that we did, which was called as TRIUMPH study. So before we go and hand it over to Ketan, let me tell you that Ketan is not only a physician par excellence, he's not only my friend, but he is now currently a Honorary General Secretary of Indian Society of Electrophysiology. Is that correct, Ketan? And also Ketan is the Vice President, Mumbai West IMA. Apart from that, Ketan has been the organizer of the Diamond Epicon, which happened in Mumbai. That was a very, very, I would say talked of Epicon. And along with that, Ketan is on the editorial board of JAPI and Journal of Medicine and Nutrition. Ketan has been faculty to so many places. I can keep on listing his achievements and all those things. Ketan would talk to you about our survey that we conducted, what we named it as TRIUMPH survey, which recently has been accepted in the conference of an American College of Cardiology conference. Ketan, talking to us about the physician-based survey. Over to you.
Thank you, Mangesh, for the kind words. At the onset, I would like to thank Dr. Seshadri and, of course, the WIPRO team for organizing such a wonderful session on the post-COVID team. And what Mangesh has told, that I would be speaking about this TRIUMPH and, of course, the post-COVID hypercoagulability. In fact, friends, after listening to the two giant speakers, and they have mentioned so well about what all things which can happen in the or after the COVID. Especially we have heard from Dr. Agam about the lung fibrosis, and especially from Dr. Manoj Bhatodekar speaking so nicely about talking about stress disorders. And now we are going to see the certain other aspect in post-COVID era in terms of cardiology. Now, this was a beautiful case series which was published by European Society of Cardiology, talking about cardiac sequelae of novel coronavirus disease, that is COVID-19. And there was a series of cases which were presented, and people started realizing, yes, what all things can happen in cardiology over here also. And that is the time, we started realizing that our knowledge was so much limited. And that reminds me the quote from Sir Isaac Newton, who states that what we know is a drop, what we don't know is an ocean. That is so much true. Now, if you look at this one initial beautiful paper, which was published in Journal of Thrombosis and Hemostasis, it was published way back in on the March 2020, when India has just started it. And they talked about, looking at a hypercoagulable state especially in COVID. And then they were looking at the 4 different parameters: D-dimer, prothrombin time, platelet count, and serum fibrinogen level. And then they were at that point of time talking, okay, which are the subjects which should be given anticoagulants. So these were the parameters which were studied at that point of time. Now, if you look at the Mount Sinai that came out with the first protocol, which was published in April 9, 2020, and they suggested that all the patients admitted with moderate or severe COVID-19, depending on their risk score, they should be anticoagulated. And this is the chart which they had recommended. I would not go into the details of this chart also. But at the same time, there was a paper published in JACC, Journal of American College of Cardiology, in June. What it shows that treatment with antithrombotics in COVID-19, and they recommended that routine screening for venous thromboembolism with COVID-19 with elevated D-dimer cannot be recommended at this point. That means you need to really look into it, all patients of COVID-19 where you are getting elevated D-dimer, you can't routinely screen for venous thromboembolism. So that means you can't subject them, all of them, for getting a peripheral Doppler done or getting a pulmonary CT angio done to look for it. But rather they recommend it is a time we should start dealing with it, start considering this as a risk factor and should be treating it. Okay, now subsequently this European Society of Cardiology working group came out with the recommendation that how should we deal with concept of or the risk of these thromboembolisms. And they divided all patients admitted with COVID-19 symptoms into two groups, one with a high risk of thromboembolism and another into low risk of thromboembolism. Obviously, high risk were admitted into ICU group and they were given anticoagulant, and the low risk, depending on the D-dimer level, they were given the different doses of heparin. That was low molecular weight heparin. So that was again the three categories of heparin. One is with the low intensity therapy, moderate intensity therapy, and of course the full therapeutic dose of low molecular weight heparin, which was given. And again, subsequently, depending on the performing the point of care ultrasound, they were decided whether to continue therapeutic anticoagulation subsequently or to de-escalate later on. So that was decided. So this was again a beautiful paper which came up over there. Obviously, till then, our own guidelines were going, changing it. There was a clinical management protocol which came from the government of India. This was from Ministry of Health and Family Welfare. And in June 2020, we got this guideline where it was made very clear that in cases of moderate or severe COVID-19, anticoagulation should be a part of it. And again, over there, it was mentioned about the prophylactic dose of using heparin, which was unfractionated heparin or a low molecular weight heparin, which is starting from moderate, not in mild varieties. And subsequently, this is the guidelines which came from Bombay Municipal Corporation, which suggested depending on the risk, low risk, intermediate risk, or a high risk, they should be treated. All these patients needs to be given prophylaxis therapy to prevent thromboembolism complications in an admitted patient. So this is what we are talking about. All admitted patients, be it low risk, intermediate risk, or a high risk. Obviously, the dosage will vary, but should receive anticoagulation. They also recommended that you may consider extended prophylaxis for 4 weeks upon discharge. So that means that during the 2 weeks they were given, and even on discharge, 4 weeks were recommended. So this created, there were a lot of confusions. People were really not knowing, the different guidelines, different recommendations which were coming, and different anticoagulants. Somebody were using parenteral agents like unfractionated heparin, low molecular weight heparin, fondaparinux, and certain groups were recommending oral agents, whether it was a vitamin K antagonist or newer oral anticoagulants in the form of dabigatran, rivaroxaban, or apixaban, which were used over here. And that was the time there was a nice editorial which was given by one of my good friend, Dr. B. Hygreev Rao from Hyderabad. This article came in IJCC as an editorial that is COVID-19 compelling us to bring out a new edition of our cardiology textbooks. And that is what is truly so. And there we started with this study called as TRIUMPH study. So I'm going to give you these insights from this TRIUMPH study. What is this TRIUMPH means? It is a thromboprophylaxis to improve outcomes in COVID-19. And it is an Indian expert consensus through virtual contribution by 810 physicians. And this is this large number, if you really look into it. Okay, so just to give you an idea, the idea behind is first to explain this how these clinical guidelines on which the bedside clinicians have grown accustomed can be created in the midst of this pandemic with an changing scientific knowledge and understanding of the pathophysiology of hypercoagulable state which is happening in COVID-19. And second basic mechanism was to adopt current venous thromboembolism diagnostic and treatment guidelines, which we need to really see how it can be best correlated in a COVID-19 patients. And finally, whether can we create a comprehensive clinical guideline or is there a need to treat for this thromboembolism in COVID-19 patients. So this was done under the banner of Academy of Advanced Medical Education with myself, Dr. Mangesh Tivaskar and Dr. Agambora. We had carried out this entire study with the help of Dr. Namit Wadhwa. We had carried out this customized technological platform specifically for the virtual response system, and 810 participants were there for the study, which was a huge number. And best to our knowledge, at that time, we did not have any study where on a virtual platform or on a virtual questionnaire, so many participants had responded to it. So that was a fantastic response which we got it through this. So what was the methodology used? Here the responses were captured prospectively from July 30 till August 24. And that was in the time duration of 26 days. Questionnaire shared on the individual WhatsApp with prior telephonic consent of the targeted respondent. So there were total 15 questions, which was like in a Google form, comprising 11 questions specifically for opinion for the best suited approach for thromboprophylaxis for COVID-19 patients. So basically, it is like a real world practice scenario. We wanted to understand what the people are believing and what they are following. And of course, at the end, an auto-acknowledgement email was sent to the respondent and the AMI team for the purpose of confirmation of completion of the question. Data was kept anonymous, so obviously it was individual response or name was not revealed, and it was analyzed by using GraphPad software version 8.4.3, which is one of the best software for analysis of the data. And ANOVA and the student t-test were used for the statistical analysis. Okay, now I would come to the results. So, mean years of experience in active clinical practice was 15 years. So what the clinicians who had participated, there were people who had just joined their clinical practice. So with the experience of 0 years to a maximum 52 years. So people who had participated in that. And I would be, very happy to see that there was across the spectrum, people the junior most to senior most people had participated for this study. And what was found that there was no statistically significant difference in the percentage of most prominent response amongst the participants. That means whether you take one group where the more than 15 years of experience, another group less than 15 years of experience, or overall, the responses were almost the same. So it did not matter whether there is a senior practitioner who is responding or a junior person who is responding also. Okay, so I would now go to the certain individual setting and what type of practice we did. Of course, the data was analyzed depending on the same Google form. So what we found that, depending on the practice setting, what was found that those who were on only outpatient or daycare practice, or those who were doing OPD practice, almost 14%. Those who were from response coming from private non-teaching hospital, but no trainees, is 37%. Private non-teaching hospital trainees were almost 19%. Private government non-teaching hospitals, no trainees 6% and trainees 21%. So predominant participation, which was more than 50%, it is coming from a private non-teaching hospital. So there was a wide distribution of the participants that we could see over here. So it definitely gives the distinctive strength of the study, because the numbers are representing across, whether we talk of academic institution versus private practice, indoor setup versus outdoor setup also. So we got across the board the responses were okay. Now, what was the belief of the practitioners or those who responded? That what do they think about the incidence of TBT? So almost every other participant, or that means almost 55% were of the opinion that less than 10% of COVID-19 patients hospitalized in non-ICU setting had incidence of TBT, despite pharmacological thromboprophylaxis. Now that's very important. We do give a pharmacological thromboprophylaxis and people were still getting the thromboembolic phenomenon. So that means the dosage what we were giving were inadequate, or the duration for which it was given was inadequate. So incidence of DVT was perceived to be a clinical challenge in a small proportion of COVID-19 population, even in the non-ICU setting. And this was of practical importance as it is opined by most of the participants. So considering what are the risk factors, what was found that, current or previous known case of cancer, it was 10%, D-dimer more than 3000 microgram per liter was 31.8%. So approximately 1/3 participants believed that D-dimer values of more than 3000 was considered as an independent risk factor, which is so much true. And today also we know D-dimer has become one of the basic investigations for all admitted patients, and depending on which we decide about the thromboprophylaxis, whether go for a prophylactic or a therapeutic dose. So importance of D-dimer as a marker for risk of thrombosis is in line with the published evidence. Of course, we have numerous data which is available, and D-dimer is a good clinical guide even at the time of discharge. Now that is very important. One is during the hospital stay, and second is pre-discharge. D-dimer will decide whether this subject would require a prolonged therapy for thromboprophylaxis. Now, here most of the participants did not consider patients on high nasal oxygen therapy or known cases of cancer to be at substantial risk of thrombosis. So it was not in their viewpoint. And of course, the evidence suggests that DVT may occur among non-ICU patients hospitalized for COVID, despite utilization of guideline recommended thromboprophylaxis. Now, another question which was there, that the COVID-19 as an additional risk factor for DVT, and the vast majority, almost 86%, considered COVID-19 as an important additional risk factor for DVT in hospitalized patients. And this definitely gives a highlight about COVID-19, which is as an independent risk factor. And therefore, it is very important for appropriate prophylaxis to be initiated at the time of admission and followed up with cost-effective, efficacious agents, which can be required during the discharge time also. Another question which was there about the universal thromboprophylaxis, and especially when we are talking in COVID-19 patients who are hospitalized and do not have an increased risk of bleeding or contraindication to anticoagulation, and this was agreed upon close to almost half of them. So more than 50% believe that each and every individual who are getting hospitalized, be it in a non-ICU or ICU setting, if there is no contraindication, thromboprophylaxis is a must. And the understanding of the natural history, which is very crucial and important, because now we know COVID-19 is considered as an immune thrombotic state, which is important. Now, when we come to the agents, thromboprophylaxis with low molecular weight heparin. So there was an agreement by more than 2/3 of the participants for the need for LMWH for thromboprophylaxis. Again, of course, in absence of increased risk of bleeding or contraindication to anticoagulation. So most of them will believe that, okay, admitted patients go ahead and start with low molecular weight heparin, which was the standard protocol. Now, what about NOACs? So is there any advantage for NOACs over unfractionated heparin, or I would say even for low molecular weight heparin? Of course, because heparin being a parenteral therapy, and in hospital also, we had seen in most of the centers, the parenteral therapy were minimized. It is predominantly only the oral therapy which is offered, unless patient desperately or patient requires what compulsive evidence to give parenteral. So more than half, that is 52% are of the opinion that there is an advantage for utilizing NOAC over heparin for inpatient COVID-19 thromboprophylaxis, which is a superior compliance and adherence with NOAC. And of course, you have the flexibility of dosing, and the cost effectiveness was also, because if you really consider for those who are getting post-discharge, the treatment for giving an injectable therapy also, that also needs to be taken into consideration. So we know that even the emerging literature is in line with these responses, which we have seen over a period of time. One more important question about the post-discharge extended thromboprophylaxis. So there has been a clear requirement for need for extended thromboprophylaxis due to the enhanced risk of thrombotic events even after the hospital discharge, and which was agreed by almost 60% of participants. And this is again a novel consensus for utilization of NOAC, because if you want to give an extended thromboprophylaxis, it would be definitely NOAC, which is there, because you can't use vitamin K antagonists, because then you will have to monitor with PT-INR, which is not possible if you want to give it in an extended period. So NOAC, which does not require any monitoring, these are the best one to use it as an extended prophylaxis to mitigate the aftermath of COVID-19 related coagulopathies and coagulation disturbances, which can prevent long-term complications. Now, what about need for coming out with the guidelines for extended thromboprophylaxis? So there is a strong need for formulating guidelines for extended thromboprophylaxis post-discharge. Those who are all admitted in COVID-19 patients and having no contraindication or any risk of bleeding, they should be given, and that was agreed by almost 60% of participants over here. And what about the NOAC as a thromboprophylaxis? So majority agreed that dosage for NOACs that are typically given for the thromboprophylaxis of the medically ill would suit the requirement of COVID-19 patients for thromboprophylaxis, and it would be favoring the statement also. About the duration of NOAC for thromboprophylaxis, it was opined that each one in 4 participants, that means 1 out of 4 agreed upon it, and few had opined that either less than 2 weeks, and 1 out of 4 has opined that it should be more than 1 month, it should be carried out. But what we found that at least 4 weeks of therapy post-discharge would be definitely an ideal one. And of course, the biochemical markers and the severity of disease could be an important clinical guiding force for that. So ladies and gentlemen, the study out from this concluded that the thromboprophylaxis in COVID-19 in hospital and the post-discharge is very crucial in a COVID-19 patients, because it induces hypercoagulability with both microangiopathy and local thrombus formation. This is critical to mitigate systemic coagulation defect that may propagate to large vessel thrombosis and major thromboembolic complications. And what we are always worried about, the disastrous pulmonary embolism in critically ill hospitalized patients. D-dimer levels should be monitored, and all hospitalized patients should undergo thromboembolic prophylaxis with an increase in the therapeutic anticoagulation in certain critical situations. And Of course, the virtual expert nationwide consensus exercise has shown favorable agreement of the participants with regards to the utilization of thromboprophylaxis in COVID-19 patients. For participating, of course, the thanks was sent by the team, that is myself, Dr. Mangesh and Dr. Agam. And we stated that we thank you for your valuable time, personalized efforts, and intellectual thoughts towards the contribution to the prestigious nationwide perception mapping survey. Staying apart keeps us together. And this paper, I was happy to say, we presented it recently completed the CSI Cardiological Society of India annual conference. And as Mangesh has said, the paper has already been accepted, which we are going to present at upcoming American College of Cardiology. So friends, I would say change is the only constant thing in the nature. We have to change with the time. Our thinking and concept need to change. And I remember Charles Darwin's words that it is not the strongest of the species that survive, nor the most intelligent, but the one most responsive to change. That is so much true. We all are changing. We have accepted the changed new norm. And I would say that World Thrombosis Day, which got over on 13th October 2020, the theme of over here was keep your eyes open to thrombosis. And that was so much true when we were talking about COVID-19 also. So we pray for the world that this is the new norm which has come up, the mask, and mask, which is there. Today, the time is come that even the healthy kiss, which has become a new norm for. Thank you so much for your patient hearing, and we would be happy to take up the questions. Thank you.
Talking as usual. Well said, Ketan. I love that Charles Darwin line. Of course, I don't want to kiss my girlfriend the way you have suggested me to kiss her. Please. Okay. Thank you for those beautiful words and nice presentation. I know it's very tough sometimes to present the data of a study, to such a lucidity. Thank you very much. And now here I will come, my one of very, very close friends. We started our medicine together. We practice together. We share a lot of things together. And Arvind, I can say, one of the loveliest, super-hearted, kind-hearted person that I know. He's not only a physician of the top brass, but also a very, very humble human. His recent talk in API on the setting up of a post-COVID OPD has created a sensation. So I just thought that we were also very selfish. And me and Agam decided that, let us have Arvind again on this platform. One of the trustees of the academy, now a very, very active member of Bombay IMA West branch, now a post holder, and now going to be Arvind, are you going to be a secretary of?
Yes.
Yes. So Arvind is going to be a secretary, or he has already taken over as a secretary of?
No, sir, tomorrow.
Yes. So perfect. So tomorrow Arvinda is going to be a secretary of IMA Mumbai West branch, and he is going to speak to us about this very, very relevant and apt topic for the day. Setting up of a COVID OPD, because we all struggled. Now, Dr. Bhatodekar talked about, how it has been difficult to, really see and interact with the patient. We all know that now with the changing norms, now we have started learning about teleconsultations. There are challenges with teleconsultation. When it comes to the Schedule H drugs and Schedule X drugs, the challenges are still difficult. Certain consultations like first consultations or even neuro consultations are very, very difficult. Agam would also love to keep his stethoscope on the backs of the patients to just find out, but then unfortunately he's not able to do that. So all this considering the challenges and along with the fear and anxiety that the people have, I would like Arvinda to tell us about how best we can set up a COVID OPD, especially in this during COVID times. I will never use the word post-COVID time, but I will say that this during COVID times. What do you, Arvinda?
Thank you very much, Mangesh. It is very nice always to be with you and Akram for any forum that you have. This is not really a lecture of any guidance lines or any studies or anything. This is basically a practical approach or an experience based approach by not me, all physicians and even a general practitioner to change your own OPD into something like a COVID OPD. You all are aware that what we had as effect of COVID-19 on health sector was due to lockdown. So many postponed elective surgeries were there. Nobody was ready to come for surgery. Even now there is a hitch. There was complete closure of OPD for so long a time. Then there was fear of contracting COVID during the hospital visits, so there were no hospital visits. And then there were over-the-counter prescriptions of medicines. A lot of self-medications people did. Lack of transport also added to the fire. And then ultimately, telemedicine was the only answer we had during that time. But now the situation has changed, and now that we are supposed to take patients in our regular OPDs, we should plan for that. What is transformed over this COVID-19 is majority of the ambulatory visits are virtual. You don't directly come into face-to-face consultations. Elective procedures are postponed and then delayed. Ward nurses working in ICU care units, because they are all, they are having extra duties, so they had to work more than their experience and their knowledge. Primary internists are providing hospital care. So even interns are put into hospital care. Even students final year are put into the job of an intern. Everyone is trying to stretch the limit of healthcare workforce to meet the needs to the greatest number of patients that we had recently. Healthcare in India is supposed to include private practitioners and hospitals, practitioners of alternative system also. A marked shortage of trained nurse obviously is there. Increased cost of medical care due to all these arrangements extra that we want to do. And threat of healthy doctor-patient relationship. There are so many misconceptions about doctors and their advices during COVID that we are supposed to face and respond to. What are the factors which affected our usual practice? During the initial phase, it was a lockdown period. Lack of transport was there. There was fear of transmission of COVID. There was less acute emergencies used to come. And then let go attitude. So let it be, forget it. Now health is not so important. Post-COVID, there is a lot of economic burden to everybody, including patients as well as the doctors. Many people have lost their jobs. Shifting for native places, many people have left off Mumbai for good. Loss of relative has given an emotional shock to them. And again, a let go attitude still remains towards the disease and problems. Very many key sectors of health system are affected by COVID without our knowledge. Just now, cancer care delivery system has affected maximally, which even I found it only on literature, that approximately 1 lakh cancer cases per month will go undiagnosed in India due to COVID not even searching for a cancer patient. Lung cancer is the most common type of cancer with adverse outcomes. 28.6% of cancer patients coming to the OPD acquired COVID-19 infection from the hospitals, a bad situation to face. Pandemic has greatly hindered cancer trials and research, a bad story as in whole. Family planning services, shortage of contraception was there and everybody was in the house. There was reduction in the manufacturing of contraceptive devices, leading to no contraception, resulting in 7 million unintended pregnancies during COVID. Injectable contraception decreased by 36% and IUD insertion reduced by 21. Naturally, there are 7 million more to handle. Mental health, just now Dr. Bandevdikar said so nicely. I'll just quickly rush through. Extremely negative impact on mental status of anxiety disorders. Substance use disorder patients may face the crisis as he mentioned. Mental health related issues and psychological morbidities in healthcare workers. Risk of anxiety depression in elderly as well as in children. There is anxiety depression and somatic disorders due to lockouts and not going out even to school or play. COVID patients and families are discriminated because they are positive. Effect of pandemic on rural health care, very bad. As such, we had rural care services with lack of workforces, absenteeism and poor infrastructure and quality of care. Healthcare system is not adequate because of the shortage of doctors, hospital beds and equipments, poor testing facilities, surveillance system, and above all, poor medical care, which aggravated during COVID, and we found the difference between a city and a village just because of that. Other diseases affected due to COVID are HIV infections, tuberculosis, and malaria. To surprise all of us, these related deaths of these three may increase by up to 10, 20, and 36% respectively in the next 5 years. This is a probable forecast as compared to the scenario where there was no COVID pandemic. So a threat of this infection to rise and the deaths also is a postulate. Worsening of glycemic control in diabetic patients is directly proportional to the duration of lockdown, and it would also increase the diabetes related complications. All of us need to look into this. Preparedness of healthcare facilities, that we should have a facility to cater COVID as well as non-COVID cases together in the same clinic. Non-COVID cases need help to minimize infection risk in the hospital. This could be achieved through physical infrastructural changes in our OPDs and emergency case setups. We will see how. Setting up a COVID OPD, then number one, set up a triage area before presentation to the center. Telephone triage, you have to have an appointment system to identify suspect cases, separate appointment timings for the COVID and non-COVID people. On arrival, ask symptoms of respiratory infection, keep them different than the others. At entrance, there should be temperature record, proper face masks, respiratory hygiene, supplies, and hand sanitizers. To wait in the vehicle or outside the healthcare system unless their turn comes, so that there is no crowding and safe distancing is maintained. You should reinforce standard hygiene practices. Told 100 times also, can there be mistakes from even doctors and the nursing staff about face masks covering the nose and mouth fully, cough etiquettes, hand hygiene and respiratory hygiene, social distancing in the waiting area, and body temperature check. Patient examining protocol, there should be minimal routine OPD work. Doctors should wear surgical masks in addition. Clinics should be well ventilated and minimize consulting time and physical examination. Of course, it should be there to the minimal possible time to avoid direct contacts with the patient. Safety for hospitalized COVID-19 patients, it should be as far as possible a single room per patient with adequate ventilation, or the bed spacing should be at least 2 meters distance. PPA for dedicated medical team. Equipment should be dedicated, cleaned pre and post checkups. Relative and visitors should have a video conferencing, not direct contact. Hand hygiene all the time, that even before touching the patient, before cleaning and having the procedure, after body fluid exposure risk, after touching the patient and after touching the patient surroundings. Everywhere there is a chance of carrying infection to yourself from the patient. Casually exposed healthcare workers should not be self-quarantined immediately. This is a result of one observation, that for medical staff exposed and unexpectedly testing positive, the quarantine recommendation should be based on the duration of exposure and the severity of the disease. Prophylactic use of Hcqs that we all talked about for healthcare workers. There is a good randomized clinical trial for 40,000 healthcare workers underway. They are receiving chloroquine or Hcqs vis-a-vis a placebo to be taken over 3 months intervals intermittently. It has begun recruiting patients, or recruiting doctors, and the results are eagerly awaited. We will come to know whether this is going to be helpful in future life. Aerosol generating procedures when we carry out, like tracheal intubation, tracheostomy, NIV, CPR, bronchoscopy, have increased risk of transmission of COVID-19, should be carried out in adequately ventilated room. Previously, we never used to give even a nebulizer in the clinical practice during COVID. HCW workers conducting such procedures should wear full body PPEs and N95 particle filtering mask. Environmental controls that we talk about, adequate ventilation and environmental disinfection is required. Management of laundry, food services and medical waste disposal should be absolutely proper. Laboratory biosafety practices should be maintained. UV sterilization has come up very well. Appropriate transport for patients and the danger material that we are carrying. Disposal of biomedical waste, there are rules of yellow, red, white and blue bags we all know about. We should follow. We should keep this chart in hand of the staff who is handling the medical waste. Access to the PPE to the health workers. There was PPE shortage initially. Many healthcare workers are forced to put themselves at a risk using substandard PPE, and that was the reason why initially in COVID, we had so many deaths just because of negligence of not wearing a proper PPE that time. PPE should include everything like face masks, a double face mask, then face shield, a goggle, gown, proper apron, gloves, maybe double gloves, head cover, and shoe cover. Everything must be there. Emotional needs of healthcare workers. Healthcare workers are physically overworked. They are mentally also stressed. They are forced to make crucial decisions of a serious patient, have guilt and pain of losing a patient and colleague naturally. Worrying about their own health obviously is there, but anxiety of passing the same infection on to their families is more worrisome than their own self. Telemedicine finally came to our rescue. It's a best practical solution for consultation. Audio video consultations are possible for diagnosis, treatment, and prevention of disease. Documentation record can be kept very well and can be reproduced. CMEs, webinars for and web conferences for all of us, it's a norm now, and we are so used to it that we daily attend as many as we can. Meetings and get-togethers are also going to be on a virtual platform nowadays. Vaccinate everybody, the last word for now, which has already been started for healthcare workers. It should go on to as maximum patient population that we have, so that we have many people having vaccinated fast will create a good immunity to all of us. So many banners and charts are made by WHO to reduce the risk of coronavirus infection. To follow these important precautions, we all should paste this as in as bigger size as possible for all the patient to repeatedly revise the guidelines and the precautions that we talk of. So to summarize quickly, COVID-19 is a challenging time, but it has given us good opportunities to learn telemedicine and digital adaptation, which is going to increase soon. Need to prepare COVID OPD arrangements is a must. Everybody should think about, and there may be addition to whatever I have said just now to in your setup, whatever is required in that particular setup, you must try and do it yourself. Health sector reforms are a need of an hour. Spending on healthcare budget has increased in the recent budget, I noticed, by 10.25% from 19,061 crore. It is increased from the old budget of 17,288. Nonetheless, something is better than nothing. So this increase is also an appreciable thing, and we have to strengthen naturally our primary health care system. Thank you very much, and over to you, Mangesh.
Thank you. As expected, Arvind, that was super duper and so simplified and lucidly presented. Yeah, of course, I completely agree to what you really rightly pointed out, those pointers that yes, we do need to have and continue to follow those guidelines which are there. So that opens up a huge galore of debate and questions and all that. So I would like Krishna to join us along with Dr. Mahesh and Dr. Vijay, if at all around there. Agam, I would like to have you, starting with this question. And there are a lot of questions which are there on vaccines. So we need to address that. So first question to you, Agam, which has been already posted, is this: that do vaccinated individuals get RT-PCR positive? And if it also, then what is to be done? How do you interpret that?
Vaccine is a hot topic, and vaccination has always been close to my heart. I've been fortunate enough to be part of vaccination strategies. I was part of the life course immunization by IMA. I am the part of Vaccination Documented, which is just recently published, and Mangesh was there with me, and we were in the team. It is the immunization by API. Also, I was part of adult immunization. I was also part of the Geriatric Society of India recommendations. So, and I myself have been vaccinating all respiratory patients who come to my OPD for almost 15 years against those influenza and pneumococcal vaccine. That question is very apt. We must understand that this vaccine gives you antibodies. It doesn't stop you from getting infected. In the sense, we have a lot of patients. There is another probably wave, you call it, or probably another surge in the cases, at least in Maharashtra, at least in Mumbai where I practice. And a lot of patients who've taken vaccines have got infection. Now you blame it to probably poor infrastructure, you blame it to overcrowding which is happening at the vaccination center, and the inability for us to realize the importance of wearing mask and social distancing, and kind of chalta hai attitude that what we've got. It is the combination of all this. But one must understand, vaccine cannot prevent infection happening. So you can always acquire infection. Only thing is, if you're vaccinated and you are immunocompetent, in the sense if your immunity is good enough, you may have milder disease, or you may not have severe disease, you may not require ICU, you may not require. So most of these patients will have a milder course of disease. Now, again, it depends on how well your immune system reacts to it. Everybody who takes vaccine need not have a very good response from immunity. So this would be very individual response. Thank you very much for that question.
Yeah, so that was so pertinent, because I can tell you that there is a case which is I'm treating currently. One of my batchmates who was vaccinated on Wednesday, from Thursday started getting fever, and she tested positive, and her whole family tested positive. She got vaccinated on
Yes, in fact,
Wednesday.
there is a urologist in Borivali, Mangesh.
Yes.
His mother and his brother both have completed second course of vaccine, and both are tested positive. CT showing 8 and 5 score.
Yes,
So that means that is what it. But luckily, both are asymptomatic now. They had initial 4-5 days of symptoms, got CT done, and then that's the state. Thank you.
Yeah, but then that's what that vaccines will surely get down on the duration of the illness, maybe possibly the comorbidities associated with chances of survival, development of complications will minimize, and it's quite possible that you will be able to handle that disease load in a better way, rather than talking about just completely stopping you from getting it. Because no matter whatever, the message is this, that you cannot stop following the COVID appropriate behavior. Just do not underestimate. As Arvind has said, that let it go. This cannot happen. There is no let it go stuff, still exists, no matter you are in the clinic or not. Now, the question to Bhatodekar sir, this is so pertinent to me. And in fact, quite a few of our colleagues, we have seen that people were reluctant to go to clinics. They were so scared about, not to go. They went into a sort of a depression, or a denial depression, or sort of, or there was a lot of mania, or sometimes even, a sort of psychosis around it. So how do you advise people, especially the healthcare providers, to keep their morals up, in this difficult situation? What are those small tips that you would like to give, to keep your morals up? You are muted, sir. You need to unmute yourself.
So sorry. Yeah. So this is a very pertinent question when it comes to healthcare providers. As I said, I have interacted with many people who are working as frontline health workers, right? And they are at a risk. So talking about them on one hand, also talking about people who are not directly frontline health workers, but doctors who are providing healthcare in their own clinics, maybe, right? Vaccination is one area which is supposed to protect, but what really protects you is your own sense of faith, trust. I'm not saying trust in an abstract entity called God or anything of the kind. I'm just saying trust in life in general. Yeah. Unfortunately, what has happened is doctors in the past few years have been looked down upon by the society. So doctors, we as a community have this attitude that we are doing great work, but we are not recognized. And now suddenly with the COVID pandemic coming up, our status has kind of gone up. But I've heard these kinds of reactions from people that once this is over, again, people will pull you down. So that's where we come from. We need to remember that we are human beings, number one. We are at a risk. So whatever precautions we need to take, we need to take. We need to do something for our stress management on a day-to-day basis. This is very, very important. We cannot neglect this. I mean, I've interacted with the head of the department, the heads of departments of medicine of COVID hospitals, personally, one-to-one I have interacted. And one of them was telling me that when I come home from the hospital, after managing a serious COVID ward, I take a bath and I enter the kitchen and I cook or I wash clothes. Simple things which or spend time with my family. Simple things, simple stress busters on a day-to-day basis are a must. And that is what ultimately keeps us happy. Happiness is very important. Happiness is a very important prerequisite to good immunity. And we need to be immune not to just infections, but various kinds of stresses, right? So we need to take care of our mental health. Nobody will.
Yeah, thank you so much, sir. In fact, that is what I would say would like to convey people that it's like only belief, self-belief is one of those key things that we follow, all of us. But we all are COVID warriors, and every one of us. And I'm very happy to quote that Dr. Mahesh Kanti is here with us, who
Mangesh,
is
let
in
me
charge
tell you
of.
one thing.
Yes, sir.
Being a warrior is one thing and being a warrior is another.
Yes.
Let us not be warriors. We are more warriors than warriors.
Warriors.
Okay?
Very well said.
Yeah.
Yes.
Krishna, yes, you want to say something?
No, I just wanted to actually interject and ask sir. Sometimes I'm very concerned about us being labeled warriors and stuff like that. I'd rather be seen as a professional. I'm doing my job. You pay me for
Exactly.
it.
Perfect. Yeah, absolutely.
Yeah, you pay me for it. I go home. I take care of my children. Yes, I have some altruism in me, but that doesn't make me anybody more special. You don't have to praise me to the heavens. You don't also have to dump me down the drain.
Exactly. So we are just plain and simple human beings equipped with some skills which we use to help people. That's it.
Yeah, so that's what I was talking about. Is that because none of us and none of our generation have been trained actually officially to handle this kind of a pandemic situation at all in our medical colleges. This was not a part of our curriculum. They tend to compare us with warriors and the war soldiers and all that. But there are two different things. War soldiers and warriors are trained they are trained that way to fight the wars and protect us. And second thing, which does not happen with a warrior or a war soldier, is this: that when he leaves the battlefield or a border and comes back home, he doesn't bring back that war home. As Arvind has very rightly pointed out, that war gets over there for a soldier, but for us a new war starts. That you can be a source of potential infection to your most loved ones for whom you live for. So I think that becomes a very
Mangesh, can I
pertinent
make
comment.
one
Yes.
more awful point? I mean,
Yes.
I know I'm
Yes.
being provocative,
No
but
question.
since we have a great panel, I also wanted this part.
Yes. Yes.
Since the other word I hate is hero
Yes.
or martyr. You know why?
Yes.
If you have to be a hero, then something in the system has gone wrong.
Yes.
I don't know if you agree with that, but
Yes.
I don't want to be a hero also.
Yes.
Let the system do its thing. I'm happy to help the system.
Yes.
But I really don't want to be a martyr or a hero. I just want to be a doctor.
Yes. That's perfect. That becomes and sometimes these are all beyond your control. That is I would say a gray line. I would say that is beyond your control. You may not wish to have this kind of tags or labels, but people, they will definitely make you. They will make you
No,
to
it's the
wear these
media.
garlands, and it's a
No, it's
media,
the
it's the
media.
people. Yeah.
And
Yeah.
when they do that, the
Yeah.
society's expectations go crazy. They look
Yes.
upon you with
Yes.
great
That's what,
expectations, which are not practical.
So these are not our demands. Never. These are all never. Simple, clear stuff that we are in. And I appreciate the contributions by Dr. Mahesh Kant. He is the head of the COVID dedicated hospital in Pune. Agam, he is
Yeah.
in charge of. Wipro has
Oh,
converted an entire one of the buildings as a COVID dedicated hospital in Pune.
really?
Dr.
Oh,
Mahesh Kant is
impressive.
in charge of the whole thing. So
Hi, Mahesh bhai. Currently, I'm at Pune only, huh?
yeah, that's what I told him.
Yeah, we'll get in touch.
Good.
Ketan, now there's a question which has come. How you talked about NOACs and all that. Is there any role of aspirin or clopidogrel
Yeah.
Where you put it? Do you want to give only NOACs, or you put like to put these people on with aspirin therapy or clopidogrel therapy along with it?
Okay. Now, very pertinent question. And in fact, recently, one publication which has come published in JACC only, Journal of American College of Cardiology, where there is one study where they have shown that there are extremely mild cases also who are even home quarantine, managed on OPD basis, even for them, where they do not fulfill the criteria for giving the thromboprophylaxis with anticoagulations. These are the subjects, they do definitely better off starting antiplatelet, which is in the form of the lowest possible dose of aspirin, be it 50, 62.5 or up to 75 milligram per day, given it up to 2 weeks post completion of their 2 weeks of isolation. So totally it may go up to 1 month over there. So there is a role which is there. So in fact, if there is no contraindication, it would be worth giving it for even those who are home quarantine, mild cases, but those who are at high risk. Say, for example, somebody who is a young hypertensive, young diabetics, underlying dyslipidemia, obesity, smoking, all these folks, it will be worthwhile giving them a low dose of aspirin in a milder cases. But remember, at the same time, word of caution, antiplatelets cannot replace anticoagulants. So those who are in moderate to severe cases or all those who are hospitalized patients, it has to be anticoagulation, anticoagulation, and anticoagulation. Thank you.
No, I agree to that, but I have a little deviation on that idea. And I don't know, Agam, how much you agree and how much Arvinda agrees on this. Really, I look at it in a different perspective. I think that it is more of a coagulation challenge rather than a platelet challenge. Now, and especially being a viral disease, you know that there is some kind of a platelet dysfunction which is already on, including thrombocytopenia related to COVID. Now, on the top of it, if you give an antiplatelet agent along with a NOAC or a low molecular weight heparin, which the patient is already on,
no, Mangesh,
would you not increase the chance of bleeding?
No, Mangesh, you have misinterpreted. It is not along with NOAC. See, the question, so
that's what I wanted to.
Yeah. No, absolutely. It is only for milder cases where they don't fulfill the criteria for thromboprophylaxis with anticoagulation.
So then, then genuinely, do they really require this? Because we all know, and Krishna will say that now it's like, now aspirin, especially for this kind of primary prevention policies, has been moving away. You all are aware about it. And in fact, it has been demonstrated to have more complications rather than, being beneficial. So, Arvind, I would like to have your input on this. You need to unmute.
Yeah. In fact, as what Ketan has said and proposed, see, only when you need anticoagulation is a separate issue and antiplatelet drugs is on a separate line. So you think of a coagulative disorder only after a moderation level of COVID, that they are going to flare up to a storm kind of thing. Then and then only. Mild cases and everything, we don't think of anticoagulation at all.
Yes.
Because we don't stop the drugs that they are taking out.
Yes.
If suppose Clopidogrel is there, we will continue that. Addition of anticoagulation is only when the cases in which you suspect that a coagulative disorder can give a problem, as in severe cases for that.
So Ketan, shall we probably put this message as that if the patient is already on with an antiplatelet on board, it is better to continue.
Yes, of course. Then, so it is still, the recommendation has not come. This is just one paper which has come, which has shown the data of a small group. This is again recently published in Feb 2021 only in JACC, where it has shown that they have definitely done a little better compared to those who did not receive, which is a small subset of population. So again, it has not yet come as a recommendation, but of course, this is what the data which is shown over there. And again, it is not for a long-term duration. It is for given for 2 to 4 weeks time. And again, with those who are having risk factors such as underlying hypertension or diabetes or dyslipidemia or smoking or obesity. That is it. Thank you.
Thank you. Now, this is a phenomenal question. I'm going to put the ball rolling. Agam, I want you to speak, and then every one of you need to be speaking this. This is a question about mutations happening in COVID times. The question is why and how often the mutations occur in COVID, And how do you evaluate using the serological criteria or genomic analysis of these mutated COVID strains? Do you really need to do that? My first question is, do you really need to do that?
It's virus nature, to survive. Like we've seen, we are aware of this happening in influenza virus, in all of the viruses. There is small changes which keep on happening. We don't really have to worry about it so far as there's a small changes which are happening, because a lot of antibodies would still work on it. And it's not, let's understand that every virus will have a lot of antigenic surfaces which are called epitomes, and you have antibodies which are targeted to various epitomes. It may so happen that there may be some mutation in some of the antigens, but the antibodies which you have against a particular epitome in that virus are still active and are still neutralizing antibodies, and it would not let that disease get worse. So I think we don't really need to worry much about it, unless, and of course, we at the same time have to be very vigilant about it. There would be expert. We are clinicians, we're not much into this, but then the appropriate authorities would be doing this kind of surveys and would probably alert us regarding a new strain or a serious strain or a serious mutation changes if that happens in those viruses. But as clinicians, we don't really have to worry about it. We need to take every COVID case with its own seriousness. We can't take that, oh, it is an old variant, so you could take it lightly, and if it is a new variant, you get more serious about it. Every case needs to be dealt with equal seriousness. Yes, Arvind bhai, you're saying something?
Yes. You need to unmute, Arvind.
Yeah. So in fact, with the same interest for somebody, I had to read a little literature and then find out what. So they are talking of 3 variants, sir, recently. One is a Brazilian variant, another one is a South African variant, and the main one which they are all worried about is a England variant, which is coming from England. Now, all of these 3, fortunately, they found that they are tested positive, like in our RT-PCR, what we are testing. So number 1 is that we can't differentiate between the 3, but they will be positive RT-PCR anyhow. Number 1. Number 2, for Brazilian and South African, they have found out that they are very mild to even our own COVID, which we had earlier. So that's a very, very good thing that those 2 strains are not at all troublemakers at all. Now, the last one, England, which fortunately has not been really positive in our cases, is the one which can go to a severity cases and which can be a trouble, but it has not come so far so much in India. So that is also a good sign. And what finally they concluded, that more and more mutations this way and variants are coming up. The strength of the bacteria, of course, that is for their own strength of the virus, but that strength will go down. So it is better to have more and more variants so that the power of the virus goes down. This is a probably a fortunate message later on. And by the time, if you are vaccinated also, there will be no more COVID. Good luck in 2022.
Yeah, then you want to have?
Yeah. See, now why Agam has mentioned about various strains and all, and Arvind just put the words to it. I must appreciate that, and must tell this panel, Dr. Agam Vora himself has gone to National Institute of Virology, which is based at Pune, to do some extraordinary work over there. That's why he's over there. He said, I will do my work at my webinar from Pune, but let me go and find out what is the strain. So his purpose is to visit NIV, to visit and meet Mr. Poonawala also. So there he is. I'm sure he is going to come back and he will get some good news with us for the strain. But the last news what we have is our vaccines, be it both Covishield or even Covaxin, both of them are effective against Brazilian as well as UK variant. Only the data against the South African strain is little skeptical, so that we are not sure about it, but it is there. So our message should be strongly that even our vaccines are efficacious against those 2 variants also. So we must strongly promote for the vaccination. Thank you.
Yeah, perfect. Thank you. In fact, I had a little different thought process going into that, as Agam has very rightly pointed out. As being a living being, as humans have a right to survive in this nature, probably all the surviving agents need to have their own rights to survive in this nature. So as we do our smart adjustments, every living organism is going to make a smart adjustment for betterment of its living. I am always mesmerized by this question, that why you get mutations and how I would. do you expect not mutation, not expecting a mutation per se is the idea which is probably needs to be little looked up. Not even two identical twins are similar. Not one father can generate two identical children. This virus, which is multiplying at the speed of light, which can become, from 1 to millions in matter of hours or probably days, do you expect that these copies to be truly identical to each other? It's a genetic material which is replicating at its own speed, at its own way, but it's not a printing machine which is happening. This is a replication which is happening. So you cannot expect any strain to be similar to the previous strain at
Very
all.
well said.
So
True.
stop comparing, and falling into that idea of being, this is a mutation, that is everything is going to be there. There's all these living beings are going to mutate to stay alive. They are going to give their best to fight us, and that's what the nature is. So I believe, let's not put our hearts and brains into that, and let's move on and probably try and implement what we know the best. I would like to have a take from Dr. Bhatodekar on this also.
No. I mean, I was listening to your comment, Mangesh. Even something that goes wrong in our computers, we call it a virus. So let's not forget that. So
now there is a question which has come, sir, for Agam. And Agam, this is a question that how do you manage? Do really you get anaphylaxis with COVID vaccines? And how do you manage this COVID vaccine anaphylaxis?
See, anaphylaxis with COVID vaccine is not really it's a myth. It's like anaphylaxis you get with any other injection. It's the injection anaphylaxis, not the COVID anaphylaxis, the vaccine related anaphylaxis. I'm yet to really witness any major complications because of vaccine. I already shared with you that probably for last 15 to 20 years I've been regularly vaccinating patients. To give you numbers, I vaccinate almost about 1,500 patients with influenza vaccine every year in my clinic. I vaccinate about 300 to 400 patients with pneumococcal vaccine in my clinic. And I'm sure Mangesh also has similar numbers. I'm sure Ketan Arvind also would be doing by and large the same thing. We have not witnessed any serious side effects. What we see is probably injection site reactions. You may have pain, you may have some hematoma formation, you may have some cellulitis also happening at times. You may have fever the next day, maybe day after. You may also get flu-like presentations in small proportion of patients, but that's it. Similarly, with COVID also, we've got patients with fever, we've got patients with some reactions here and there. In fact, Ketan has diagnosed one of a leading IMA members with optic nerve, Ketan, or with your sixth nerve. I think sixth nerve palsy. You unmute. Sixth nerve palsy, probably that was diagnosed, and that was again a vaccine-related complaint. So you may see one or a few cases here and there, one in million, but I think those should not be taken into consideration. We must vaccinate each and every individual in time to come. Currently, as per the recommendations, all people 45 plus with comorbidities and all 60 plus senior citizens must vaccinate themselves. Unless we vaccinate, it is our duty to nation. The vaccine that you are taking now is your contribution to development of herd immunity for our nation. Least you can do for your nation, I believe. Thank you.
Yes.
Dr. Agam, Agam, just a question here. Sorry,
Mangesh. Yeah, absolutely.
There is a discussion of the duration of second dose. Have you got any concrete basis?
Yes.
Whether it is 3 months or 1 month?
We are in a learning phase. We know that currently the task force has accepted 4 weeks as the repeat dosing schedule, and we have to look at various aspects. We are not looking only at immune reaction. We are also looking at the operational issues, the administrative issues, etc. And it is very difficult to change those protocols every now and then. But I agree, if you take it later, the chances of antibody productions or better immune reactions are brighter. I believe I myself wanted to take it after 6 weeks, but probably had to take it a little early because I had to leave, I had to go out of town. And I believe 6 to 8 weeks would be the ideal time for the second dose vaccination. But then again, I think we must follow what is available national or the local guideline.
And more importantly, this is that, whether it is 4 weeks or 6 weeks or 8 weeks, we need to have a second shot to just boost up your immunity. Now, there is a question which has come up, is this that there is an hesitancy in the healthcare providers as far as the vaccines are concerned. And if the panel allows me, I'll try and address that challenge. Is this that you need to understand that being a healthcare professional also, we have been exposed to all this virus. There is no reason for the uncertainty. My simple question to those who have challenges is this: that do you ask your child before vaccinating that do you need a vaccine or shall I give it to you or not? You vaccinate the child immediately when the child baby is born. You immediately vaccinate with the BCG vaccine. You give polio. You give triple vaccine. All possible vaccines you give. Do you ever think about a single minute that is my child ready for getting vaccinated? Is my child, is going to have any reaction with the? No, not at all, because you feel that you have a data to back up. Similarly, we have got a similar kind of a vaccine, which is the same technology which is being used, the same principles are being used. Why at all you should think about vaccinating yourself when you are all so well prepared to actually treat if at all there are any challenges to come? So when it comes to your children, you don't think to whom you love the most. You don't even think for a second. You follow the national vaccination protocol. Then why the question should come in your minds that whether should I, being a healthcare professional, be hesitant to take this vaccine? I believe that is completely wrong. All healthcare professionals, no matter whatever is the age, whatever the associated comorbidities, must get vaccinated. Each and every one of us should get vaccinated. All of us on this panel have been they have been vaccinated, either 1-2 vaccines. Everybody has finished that. I'll end up the whole with the last question to Dr. Bhatodekar, and then one quick comment from each and every one of you. Is this that, Bhatodekar sir, I want to
Mangesh, can I
yes,
sorry
please.
to bother you.
Yeah.
Just also your comment on this. Just this week, the CDC has come out and said that if you're in a room full of people who have already gotten the vaccine, you don't need to wear a mask.
Yeah.
And I mean, this is
a bold statement. I'll say that is a bold statement still.
I do not agree to this.
Yes, but that is a bold statement, but maybe possibly. But I have a feeling that, unless and you continue to stick to COVID appropriate behavior, you will never come over this disease at all. So I think probably the CDC must have said it in some different perspective. That way also let me be very honest to you that the stand taken by CDC on various different aspects of COVID has been really challenging and questionable. That is the reason why probably US is in a different zone altogether in comparison to the rest of the world. So I believe we need to take it with a pinch of salt. Agam, what do you want to say?
No, I think CDC would have seen the slide that Ketan flashed, about kissing a girlfriend with mask on. And when Mangesh also expressed his desire, and I was really amazed by his capacity to make such statement that he wanted to kiss a girlfriend, that too when he's at home and when Shilpa must be around. I was really worried, and I thought that must be the reason CDC would have come out with such statement. But then to my mind, it is not acceptable statement.
Thank you.
What is not accepted is what? The kissing with a mask on or not wearing the mask? What is it?
Guys, this is a family channel. Thank you.
Yes, thank you. Bhatodekar sir, I would end up the whole discussion. It can go whole night, and I'm sure that there still will be questions floating. But I want to ask a very, very pertinent and a very serious question. As the parents, their approach to their kids as far as this new normal which is kids are exposed to. The kids are exposed to excessive screen times because of this, learning on the e-platforms, maybe addiction, their time which is there, they're spending more time in-house rather than going out. They have reduced down their outdoor timings. The exercise has gone down technically to negligible. And how would you like the parents to address this challenge? I know this is a different question, but it is still related to this COVID platform. I need your, because let me tell you folks that Dr. Bhatodekar is one of the prime KOLs as far as the child health, and he has written a book on how to, upbring your child. And his recent paper where he quoted Khalil Gibran's poem, I still have encountered that in my research work, where he talked about the parenthood and the child health.
See, to answer your question briefly, let me tell you one thing. The essence of parenting is not about preaching. It's about setting role models. So children essentially look at their parents and learn. And this has been happening since ages, right? So given any situation, now this pandemic situation is a very novel situation for all of us. So even as parents, we were not prepared to face this situation. The point is, parents use certain coping strategies to come back to normal life. That's what we call the resilience. So various resilience building strategies that parents keep using in their own life. It could be following a healthy lifestyle. It could be taking exercise regularly or not missing exercise. Let me put it this way: not missing it, not doing it regularly, not missing it because it's that important, or spending time together. Now we are at home, so deliberately putting the screen aside for some time and giving time for interactions, talking about some myths which children are likely to hear, overhear, and just passively absorb. So there needs to be discussion. Parents need to find some time to listen to their children. Come on. It's not about preaching. It's not about talking. It's not about advising. It's about being with children and being not physically, emotionally. So when parents listen to a child, they need to listen for feeling. They need to listen for meaning. And that is what matters, If that is done regularly on a regular basis, I don't think, and then children feel very safe in the company of parents who trust them. So trust is the foundation of parenting. I mean, I can go on talking like this, but
I know.
I'll stop here.
I understand
Sir,
this.
before the COVID times, I used to love my children, when I used to get probably 1 hour and 2 hours of time with them. I used to really crave for more time. But during pandemic, when I started spending more time, I realized they are terrors, and what they talk, you hardly know. So the music they listen, the video serials they check, you know nothing of it. And when they talk, you're like alien sitting there without realizing what discussions are going on.
Absolutely.
So I think pre-COVID time was better. 2 hours a day, children is good enough. More than that, that probably gets on your nerve.
So I would immensely thank the entire team. I would immensely thank Krishna and the entire GCC MC team for allowing us to share this screen and time. I would immensely thank all the delegates, those who have spent their Saturday evenings with us. And I would immensely thank my friends, my team, including my teacher, Dr. Bhatodekar, Dr. Ketan Mehta, Dr. Arvind Gongane, and of course my soulmate Agam, for superb deliberation, very quiet, very jovial as usual. And I'll end up this session with the same Khalil Gibran poem that Sir has put in his paper. And I'll just read through this, that your children are not your children. They are the sons and daughters of life's longing for itself. They come through you, but not from you. And though they are with you, yet they belong not to you. You may give them your love, but not your thoughts, for they have their own thoughts. You may house their bodies, but not their souls, for their souls dwell in the house of tomorrow, which you cannot visit, not even in your dreams. You may strive to be like them, but seek not to be make them like you. For life goes not backward, not tarries with yesterday. You are the bows from which your children as living arrows are sent forth. Khalil Gibran for you. Thank you very much for being there. Thank you. I wish you all a very best. Good night, everybody. Stay safe, stay happy, as Bhatodekar says. And believe in yourself.
Thank you very much,
Thank you very
Mangesh.
much.
You did
Thank
it
you,
so well.
everyone.
You conducted programs so well.
Mangesh,
Thank you, everybody. Had
you
fun.
were as splendid as ever.
Well conducted.
Thank you. Thank you very
Thank
much.
you. Bye.
Thank you. Bye-bye.
Bye,
Bye,
Krishna.
Seshadri
Bye.
sir.
Bye.
Bye, bye everyone. Thank
Bye.
you
Love
so
you,
much.
Krishna. Bye. Bye.
Bye. Thank you so much.
Bye.